If you live in the U.S., you know the feeling.
Yeah.
That constant low-grade anxiety about healthcare costs.
Oh, absolutely. The sky-high premiums, the bill you get in the mail, that makes no sense.
Right. And you just get this feeling that the whole system is, I don't know, fundamentally broken.
Well, that's actually the perfect place to start, because the sources that you, our listeners, sent in make a really provocative argument. They say the system isn't broken at all.
That's a bold claim.
It is. The argument is that it's a perfectly functioning economic machine. It's designed to be expensive. It's built to restrict the supply of doctors and to legally incentivize inflation.
Wow.
And to really understand it, you don't need to know medicine. You just need to know two numbers: the year 1997 and the percentage 85%.
Okay, so those are the keys, 1997 and 85%. Our mission for this deep dive is to unpack what those mean, to look at these economic seals that keep the prices locked in.
Exactly.
So where do we start? Let's start with the supply problem. The doctors themselves, that's tied to 1997, right?
Yeah. It is. And it's the best place to start because, in any other market, this problem would solve itself.
What do you mean?
Well, think about it. If there's huge demand for, say, AI engineers, their salaries go through the roof, right?
Right.
And then what happens? Universities, coding boot camps, they all rush in to train more people, supply goes up, and prices or salaries eventually stabilize.
But that just doesn't happen in medicine. We have this chronic shortage of doctors, and yet nothing changes. The market doesn't seem to fix it. Why?
It's because of a single piece of legislation. It's called the Balanced Budget Act of 1997.
Okay.
And this wasn't even really a healthcare bill, It was about cutting the federal budget.
Yeah.
But buried inside it was a provision that, well, it froze the number of medical residency slots that Medicare would fund.
And the residency is everything.
Yeah.
You can be the top graduate from Harvard Med, but if you don't get one of those residency spots...
You're not a doctor.
Yeah.
Not legally. You cannot practice medicine in the United States, period.
So we're graduating more and more people from medical school.
We are. Med schools have expanded like crazy. But the number of jobs, the mandatory training slots, has been frozen in time since 1997. So every single year, you have thousands of qualified, brilliant med school grads who literally can't get a job in their own profession.
They're locked out. The sources call this an artificial guild, right?
It's a perfect description. You're artificially limiting the labor supply, which guarantees that the price for that labor doctor services stays incredibly high.
Okay, so that raises an obvious question for me. If doctors are so scarce, why don't private hospitals just, pay for more residency slots themselves, take up the slack?
That's the million-dollar question. And the answer is it's just too expensive and risky without that government subsidy. A residency program costs a fortune to run. You have to pay the residents. You have liability for them.
And why bother when the current scarcity is working out so well for them financially?
Precisamente. Why would they spend billions to train their future competition and drive down their own prices? The incentive is to keep the supply tight. It's a cartel, basically, but it's one enforced by federal law.
So let's play this out. What if we did uncap it? What if we just flooded the market with doctors? The sources say we wouldn't just get cheaper hospitals. We'd get a whole new kind of healthcare, this focused factory model.
Right, and you have to picture the difference here. Think about a regular general hospital. It's this massive, complex, inefficient beast.
Right.
You have a surgeon who, in one day, might do a knee replacement, then a gallbladder, then an appendix.
All in the same operating room.
Exactly.
Yeah.
So the room has to be constantly reset. The equipment has to be super expensive and do everything. The staff needs to be trained on dozens of procedures. All that overhead gets baked into the price of everything. So a simple hernia repair might cost, what, $15,000?
Okay, so that's the general hospital. What's the focused factory?
It's the complete opposite. It's radical specialization. So imagine a clinic that does nothing but hernia repairs. All day, every day.
40, 50 of them a day.
Right. The surgeons become incredibly fast and good at that one thing. Complications go down. The equipment is cheaper because it only has one purpose. The whole process is an assembly line. And suddenly, that same hernia repair doesn't cost $15,000, it costs $2,000.
And we already see this in a few places, don't we? So LASIK surgery is the classic example.
It's the perfect example. Insurance doesn't really cover it, so it's a cash market. You see prices posted on the wall, and they've been going down for 20 years because of competition and this factory model.
So the only thing stopping us from having a colonoscopy factory or a knee scope factory is that we just don't have the doctors to staff them.
That's the bottleneck. Private equity would fund these things tomorrow if they could find the labor, but they can't. The 1997 cap makes that entire competitive model impossible.
So that's the first seal, the 1997 labor cap. But okay, even with a limited supply of doctors, shouldn't big insurance companies be hammering hospitals on price? I mean, they're huge. They have all this leverage.
You would think so. But this is where it gets really interesting and really perverse. The law actually punishes them for saving money.
What?
And that brings us to our second number, 85%.
Okay, unpack this for me.
This comes from a rule in the Affordable Care Act called the Medical Loss Ratio, or MLR.
The MLR.
What it says is that insurance companies must spend between 80 and 85% of every dollar they get from premiums on actual medical care, doctor's visits, hospital stays, drugs.
So only 15 to 20% can go to their own admin costs. And profit.
And profit.
Yeah.
Now, the intention was good, right? Stop insurers from being too greedy.
Sure, sounds good on the surface. Make sure our premiums are paying for care.
But look at the incentive it creates. It completely flips their business model. Before this rule, how did an insurer make more money?
By spending less on care. By negotiating prices down.
Exactly. Every dollar they saved was a dollar they could potentially add to their profit. Now it's a cost-plus model. Their profit is legally capped as a percentage of total spending.
Oh, I see where this is going. So the only way to make more profit is to make the total spending go up.
I got it. Let's just do the quick math. Let's say we're talking about a knee surgery. In scenario A, you, the insurer, negotiate really hard. You get the price down to $10,000. Your 15% cut is $1,500.
Okay.
Now, scenario B, you don't negotiate so hard. You let the hospital charge an inflated $30,000. You just pass the cost on to your customers and higher premiums.
My 15% cut is now $4,500.
You just tripled your profit by being less efficient, by letting costs explode. The MLR rule literally gives them a legal fiduciary duty to their shareholders to encourage medical inflation.
That is insane. They went from being cost watchdogs to being accelerators.
They're cost-plus contractors. Their job is no longer to contain costs. Their job is to manage a giant, ever-growing pile of money and take their percentage off the top.
And because prices aren't transparent, the employer or the consumer who's actually paying the premium, they have no way of knowing this is happening. They just get a bill for a 20% increase next year.
And they're told, well, that's just what healthcare costs. The MLR rule provides the mathematical engine for that inflation, and the lack of transparency hides the crime.
Wow. Okay, so we have the 1997 rule creating a doctor shortage, and the 85% MLR rule making insurers want higher prices. But there's one more piece, right? Something that stops those cheaper, focused factories from ever even opening their doors.
Yes, the third and final seal. It's often called the competitor's veto.
The competitor's veto.
It's a type of state-level regulation called a certificate of need law, or con law. About 35 states have them.
And what do they do?
Well, the original idea decades ago was to prevent the overbuilding of hospitals, to stop 3 hospitals from all buying an expensive MRI machine when the town only needed one.
Another good intention.
With a disastrous result. In practice, today, what it means is this. If our cheap, efficient hernia factory wants to open up shop, it first has to apply to a state board for a certificate, proving that the community needs another hernia provider.
They have to prove a need for a cheaper, better service.
Yes. And here's the kicker. Who sits on that state board that votes on the application?
Let me guess. Executives from the existing, expensive general hospital across the street.
Often, yes. The very people who stand to lose millions if this new, cheap competitor is allowed to open.
That's the veto. They just vote no.
They vote no every single time. They'll say it fragments care or destabilizes the local healthcare ecosystem. It is the literal economic equivalent of forcing Burger King to get McDonald's permission to build a new restaurant.
And of course, McDonald's is going to say no.
Wow. So the system is completely locked down. You can't get the doctors, the insurers don't want to pay you less, and you can't even get a permit to open the building.
It's a three-legged stool, a perfectly stable, high-cost system. Every single player has a powerful financial incentive to keep things exactly the way they are.
Okay, so if that's the problem, what's the solution? According to the sources, how do you break these seals?
It has to be a three-part attack. You have to break all three seals at once.
Okay, what are they? 1. Uncap residency. Abolish the 1997 cap, flood the market with doctors, and break the labor monopoly. 2. Repeal the MLR. Let insurers keep the money they save.
So they'd actually be rewarded for finding cheaper options. They'd start competing on price, like Geico and Progressive do for car insurance.
Exactly. They would become your shopping agent again. And 3. Abolish con laws. End the competitor's veto. Let anyone who can meet the safety standards open a clinic.
And if you did all three of those things, the sources predict this massive change. A bifurcation of medicine.
Bifurcation, yeah. It just means the system would split into all the routine stuff, and that's like 90% of healthcare, right? Colonoscopies, blood tests, joint replacements, prescriptions. That would all move to those super efficient, cash-friendly focused factories.
With prices on the wall competing with each other.
Exactly. And the other 10%, the really complex stuff, the cancer care, the major trauma, the rare diseases, that stays in the big general hospitals.
But here's the key, right? If 90% of your costs are now being handled in this super cheap competitive cash market, the cost of insurance for that other 10% of catastrophic stuff would.
It would plummet. Insurance would become what it's supposed to be. True insurance for rare, unpredictable, high-cost events, not a convoluted payment plan for everything. The price would crash.
That's the disruption. It's not just making the old system cheaper. It's creating a whole new parallel system for most things.
It moves the cost burden out of the regulated system and into a real market.
So, to just bring it all home for you, the listener, the argument is that the U.S. healthcare system isn't really broken. It's a fortress protected by three regulatory walls. The 1997 labor cap, the 85% inflation rule, and the Keon law veto.
And until you address those specific structural walls, any other reform is just, it's just rearranging the deck chairs.
This is such a powerful way to look at it, because it stops being about who is a good or bad person and starts being about incentives, about economic design.
And you see how a well-intentioned rule like the MLR can have these just awful, unintended consequences. It institutionalized inflation.
It really does change the whole conversation.
Yeah.
Because if most routine care became so cheap that people could just pay for it with cash, like they do for a new TV, the need for that big, comprehensive, employer-provided health insurance plan just kind of melts away for a lot of people.
It becomes much less important.
So here's a final thought we want to leave you with. What if the real political debate we should be having isn't about how to get everyone universal coverage, but instead about how to make 90% of healthcare so cheap that we eliminate the need for routine coverage in the first place?